Hello everybody, this is Dr. Nadeem and we are with Neelam Pathology Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We have a Telegram group which you can join the group for. It is very helpful for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the Google Drive and the YouTube. These are the disclaimers. And we are with phase 3, which is recorded pathology lecture. And we are in continuation with our uropathology lectures. And today's topic is prostate, anatomy, histology, immunohistochemistry, and grossing strategy, basic approach to prostate. And to talk on that, we have Dr. Mitadru De Sarkar, who is an MBBS from JIPMER, MD from JIPMER. Dr. Sarkar is a consultant histopathologist at the famous Dr. Lal Path Reference Lab in Kolkata. He's also a consultant histo and cytopathologist at the Calcutta Heart Clinic and Hospital, an NABH accredited multispecialty hospital, and a consultant histopathologist at the Wizderm PathLabs, a specialty dermatopathology laboratory. He has been an ex-assistant professor in the Department of Pathology at the SMV Medical College and Hospital, and an ex-consultant pathologist at SRL Diagnostics, Fortis Hospital, Kolkata. Here I would like to mention that Dr. Mitadru De Sarkar has authored a book which has been published, which is on brain tumor pathology for postgraduates. This is available on Amazon. So anybody who would like to go, and you can go and read this book as well as buy the book. These are the details of the book, Brain Tumor Pathology for Postgraduate. It is very, very good book. So I would request now Dr. Mitadru De Sarkar to start his lecture on prostate, anatomy, histology, immunohistochemistry, and grossing strategy. Over to you, Dr. Mitadru De Sarkar. Thank you.
Hello, and welcome to this introductory discussion on prostate. This is the first of a 5-series discussion, 5-chapter discussion that we shall have on prostatic pathologies. The order of discussion being the first topic, which is basic anatomy, histology, immunohistochemistry, and the grossing strategies of radical prostatectomy specimens. Following which, in the next lecture, we shall move on to the various hyperplasias, the pseudo-neoplastic entities, and the prostatic intraepithelial neoplasias, along with atypical small SNR proliferations. Subsequently, we shall move into SNR adenocarcinoma, talk about the conventional pattern and some of the unusual histologic patterns that we see in daily practice. And having finished the bulk of the prostatic malignancies, that is SNR adenocarcinoma, we shall move into the relatively uncommon entities of ductal adenocarcinoma, intraductal carcinoma, and the various comous neoplasms of the prostate. Now, with a thorough understanding of the various kind of prostatic neoplastic malignancies, especially the carcinomas, we shall move into the final discussion on the fifth lecture, that is based on the Gleason grading system. We shall have a comparison of the original Gleason grading system with the various ISAP modifications which are put up in 2005, 2004, and the latest being the 2019 modification. So let's move on to the basic prostatic anatomy. I'll try to keep it as short as possible and only concentrate on that part of the prostatic anatomy and histology which is relevant from the surgical pathology point of view. So the prostate is an organ which is nestled between the bladder base and rests on the urogenital diaphragm. It is separated on its posterior aspect from the rectum by a condensation of the fascia known as the Denville's fascia or the rectoprostatic fascia. This is a very tough zone which does not allow the cancer of the prostate to spread into the rectum usually. And you also have these Cowper glands, that is the bulbourethral glands, which open into the prostatic urethra at the point of the exit. Now, this particular gland is an important structure in that sometimes it can be misdiagnosed as SNR adenocarcinomas, especially of the hypernephroid variant. We shall be talking about that when we come to the pseudo-neoplastic mimics of prostatic carcinoma. And this is a very important structure, that is the seminal vesicle, which is inserted on the posterior superior aspect of the base, and it serves as an important orientational landmark, as we shall see subsequently. So now if you look at the the fresh specimen of the prostate, this is how it looks. And there are a few important anatomical landmarks which you have to be very well aware of. The first being the base of the prostate, on which the base of the bladder basically rests. And you have the opening of the prostatic urethra, which runs all the way through the prostate, through the prostatic parenchyma, and ultimately opens into the apex. Now, this base and the apex are two important margins which will have to be sampled in the entirety when it comes to grossing the radical prostatectomy specimens. The orientation of the prostate is achieved by knowing the fact that you have the seminal vesicle and the vas deferens, which insert on the posterior superior aspect of the prostate. So in this particular picture, the prostate is actually facing you, and you can see the anterior surface in front and the posterior aspect behind, where the seminal vesicle and the vas deferens basically insert. And you have a small amount of condensation of the fibromuscular stroma, which you see on the anterior aspect of the prostate, which is marked out in blue. So you will see the same when it comes to the histology, the whole mount sections that we shall see subsequently. So that's the way of orienting the prostate. So basically pay attention to the insertion of the seminal vesicle and the ductus deferens, which will basically point out the posterior superior aspect of the prostate, and the rest of it is then easy to decipher. The first thing that you should do is run a probe through the base, at the opening of the prostatic urethra, and run it through the apex, following which you will obviously ink the specimen. We shall be talking about that in detail when we reach the radical prostatectomy part. So now before we talk about the histology of the prostate, we will have to talk about some of the three important orientational zones as far as it's the histology that we are talking about. This is because these three zones are the ones which are routinely sampled in the core biopsies. You would have seen the mention of the core biopsies being given as right and left apex, mid prostate, and the base of the prostate, the peripheral zones as well as the central zones. So we shall talk about these three important orientational histological levels in detail and see the variation of the prostatic histology that happens across the zones. So at the base, at the inferior portion of the prostate, you have got the apex. Moving up, you have got the mid prostate, which is usually the level where you get the verumontanum. Now it's an important histological landmark, and we shall be talking about the histology of the verumontanum in detail as we move on in this discussion. And of course, at the superior aspect, you have got the base of the prostate, where the bladder basically rests on the prostate. And here for orientation, you see the second picture is actually the posterior surface, where the seminal vesicle and the vas deferens are getting inserted. So we shall talk about these three zones now separately from the histological perspective. Before moving on to the histology, let's have a little bit of conversation about the various zones of the prostate. Now, this beautiful picture actually illustrates the three important zones that you see in the prostate. The first being the central zone, which is marked out in orange. The second being the transitional zone, which is basically marked out in blue. And the last being the peripheral zone, which is marked out in green. Now, if you look at the three levels of the prostate that I've talked about, the apex, the mid prostate, and the base, you'll see that the base of the prostate is the one where you get mostly the central zone and the peripheral zone of the prostate. And this yellow, the part that is marked out in yellow, is actually the condensation of the fibromuscular stroma that you see towards the anterior aspect of the prostate. As you move down towards the mid prostatic levels, you see that this particular zone is actually endowed with all the three compartments. You have got the fibromuscular stroma in front. You have got the transitional zone, which is marked out in blue. You also have the central zone with the vas deferens, basically the ejaculatory duct running through it. And towards the outer aspect, you have got the peripheral zone. Moving down towards the apex, you see actually there is a absence of both the central zone as well as the transitional zone. You only have the peripheral zone at the apex, and with the condensation of the fibromuscular stroma towards the anterior aspect of it. Keep those things in mind when you look at the three levels from the individual point of view. Now, so we shall start our journey from the inferior portion and then slowly work our way up to the superior aspect of the prostate. Now, coming to the apex of the prostate, which is the most inferior zone, you see the condensation of the anterior fibromuscular stroma in front. You have the well-developed peripheral zone, which is seen towards the posterior as well as the lateral surface. And you have got a little bit of elongation on the posterior wall of the prostate, which is known as the promontory, which basically pushes into the prostatic urethra. In front of this prostatic urethra, you have got a condensation of the muscle known as the semicircular sphincter. So you can see that there's a well-developed peripheral zone towards the lower aspect of the prostate. And moving slightly up, you still see that there is this promontory, which is basically on the posterior wall of the urethra and which points towards the anterior fibromuscular stroma, where you don't see any glands per se. And this is the well-developed peripheral zone, which is seen on the posterior as well as on the lateral aspect of the inferior part of the prostate. Now, moving a bit above towards the level of the mid-prostate, basically at the level of the verumontanum, this is oriented in a way that the part of the prostate which is shown in double arrows is actually the anterior part of the prostate. You have got this particular structure known as the verumontanum, which is basically a structure known as the utricle of the prostate, along with the insertion of the ejaculatory ducts onto both of its sides. So the utricle is basically lined by the prostatic urethral lining, and it has a condensation of glands within it known as the verumontanum. And on both the sides of it, you have the insertion of the ejaculatory ducts. So now let's see the same level in a histological whole mount section. So you have got this verumontanum, which is basically an indentation, kind of a diverticulum that pushes into the posterior aspect of the prostatic urethra, where you get these condensations of verumontanal glands. There's the mucosal glands. You have the insertion of the ejaculatory ducts on both the sides of the verumontanum. And you see there's another interesting thing happening over there. There's a well-developed transitional zone now seen towards the mid part of the prostate, which was not seen priorly. And towards the posterior and the lateral aspect of the prostate, you still have the peripheral zone. Now, this transitional zone is important because this is the zone that basically gets enlarged in benign prostatic hyperplasia, resulting in the compression of the peripheral zone that you see in the picture number B. Now, talking about the verumontanum, basically I've said that the verumontanum is a structure known as the prostatic utricle, which basically forms a diverticulum into the posterior aspect of the prostatic urethra, and it has a condensation of mucosal glands within it. And this is how the glands look. On their own, the glands don't really look very scary. They don't look atypical. You have got this bilayer, which is always a good sign within the prostate. You have got the layer of basal cells, which is identified along with the central layer of the acinar cells. And the problem is sometimes in the cross section, these glands can give an impression of malignancy, and verumontanum mucosal glands are well known to be a pseudoneoplastic mimic. And one important structure which is present in this particular glands is this layer of eosinophilic corpora amylicia, the presence of which within the glands, however atypical might be it might look, is always a sign of a benignancy. Now, again, this is the verumontanum basically in detail. You have got the prostatic you have got the utricle, which is lined by the prostatic urethral lining. You have got this condensation of the verumontanal mucosal glands, and on both the sides of the verumontanal mucosal glands, you have the opening of the ejaculatory duct. And you see these verumontanal mucosal glands are condensed in the second picture, but you see the corpora amylicia within them, which is always a sign of benignancy. So this is the opening of the ejaculatory duct, which is basically it is a combination of the excretory duct of the seminal vesicle along with the ampullary portion of the vas deferens. And in the second picture, you basically see the verumontanal mucosal glands with the opening of the ejaculatory duct on both the sides. Now, I've been talking about the ejaculatory duct and the seminal vesicles, and this is the next important histological orientational landmark that we shall talk about. So now this tubular structure, which has got a lumen and where you have this complex papillary infoldings within which are pushing into the lumen, is the ejaculatory duct. One important thing to differentiate the ejaculatory duct from the seminal vesicle in the cross section is that around the ejaculatory duct there will be no muscular condensation. You will just get a loose fibrovascular stroma, unlike the seminal vesicle where you have a condensation of the muscle bundles around the seminal vesicle tissue. Otherwise, the histological, that is the lining epithelium of both the seminal vesicle as well as the ejaculatory duct, are more or less similar. And both of them could actually be neoplastic mimics. We shall be talking about that subsequently. So this is a histological image of the seminal vesicle. You see that this has got a more or less a similar histological picture as that of the ejaculatory duct. You have got a hollow lumen in which you have this complex papillary infoldings and invaginations which are pushing into the lumen. One important thing is that some of these complex papillary invaginations could be sectioned tangentially, and in that case you might have what looks like a proliferation of query atypical glands, in which you might be actually tempted to give a mistaken diagnosis of an adenocarcinoma. We shall be talking about how we can separate a conventional assigned adenocarcinoma from misdiagnosed seminal vesicle glands. Subsequently, there are some important histological features that you need to make note of in order to differentiate between the two. And this is the gross orientation, which we have already talked about. The insertion of the seminal vesicle and the ductus deferens is always on the posterior superior aspect at the level of the base of the prostate. So this is again another histological picture of the seminal vesicle where the lumen has not yet opened up, but you see this complex proliferations protruding into a structure which will turn out to be the lumen as you go lower down. And you have got this condensation of the muscle bundles which are seen around the seminal vesicle tissue, as you can see in a higher magnification in the image on the right. Now let's look at the complex papillary infoldings which basically grow into the lumen of the seminal vesicle as well as the ejaculatory ducts. You see that the lining of the cells is basically the elongated columnar epithelium, and sometimes these papillary infoldings, like I've said, because of the problems that arise with improper orientation of the sectioning, could give rise to a pattern of query tubular glands which might act as a adenocarcinoma mimic. However, there are some important things to keep in mind. Look at the image on the right. It's obvious that there is a significant amount of pleomorphism over here. Some of these cells are pretty large, hyperchromatic looking, and markedly atypical compared to the background cells. So this kind of pleomorphism is unusual in a prostatic assigned adenocarcinoma. Remember that prostatic assigned adenocarcinomas are actually characterized by the monomorphism of the cancer cells, whereas here you have a striking amount of pleomorphism that should set some bells ringing. And at the same time, you will have to look within the cytoplasm of these cells and appreciate the fact that you are seeing some amount of pigmentation within the cytoplasm of the cells. Now, this kind of lipofuscin-like pigment which accumulates in the seminal vesicles as well as the ejaculatory ducts will never be seen in a prostatic assigned adenocarcinoma gland. So over here, you see the striking range of pleomorphism that is seen in the seminal vesicle epithelium as well as the intracytoplasmic pigments, two very important points to differentiate a prostatic assigned adenocarcinoma from the inadvertently sampled seminal vesicle tissue which might have been accidentally targeted during the process of biopsy. This is an actual histological sections from one of my routine prostatectomy specimens. And as you see, there's a well-developed lumen in which you have these complex papillary infoldings, and I appreciate the very well-developed layer of smooth muscle around this structure. Okay, but again, looking into it at a higher point of view, see that because of the sectioning, some of these papillary infoldings appear to look like query atypical tubular glands. But then again, you'll have to appreciate the fact that there is quite a good amount of pleomorphism between the cells, and you get to see this intracytoplasmic pigment as well. Like I said, this seminal vesicle tissue is not going to be an issue for you in the case of radical prostatectomy, obviously, because at the time of grossing, you know the sections which you have submitted from which particular level. But the problem is going to arise in a true cut biopsy, wherein this crowded proliferation of glands could sometimes be mistakenly diagnosed as an assigned adenocarcinoma. Keep those two important points in mind when you approach such cases. The pleomorphism and the pigment within the cytoplasm should act as diagnostic clues to avoiding the pitfall of calling a seminal vesicle tissue an assigned adenocarcinoma. Now, moving up from the midpoint at the level of the verumontanum, we go higher up at the level of the base of the prostate, where you see the prostatic urethra. There is still this invagination going on to the posterior aspect of the prostatic urethra. You have a condensation of the stroma, which is known as the preprostatic sphincter at this particular level. And over here, the important thing is that you get to appreciate almost all of the levels. You are seeing that the bulk of the prostate is actually occupied by the zones of the central glands, whereas the peripheral zone is still appreciable towards the lateral aspect. And you have some amount of the transitional zone as well, although the glands in the transitional irrigational zone at the level of the base of the prostate will not be as well developed and large as you see in the level of the mid prostate at the level of the verumontanum. Now, there are a few other glands that we need to talk about as far as the prostate is concerned, simply because you might sometimes mistake them as a malignancy if you are not aware of their existence. So you have got the prostatic urethra running through the middle of the prostate, and around this you have these glands, which are the periurethral glands, which are basically abortive ducts and acini, which are lined by urothelial cells with a characteristic elongated nucleus with sometimes the longitudinal nuclear grooving that you can appreciate. And towards the more distal portions, they can sometimes be lined by prostatic acinar cells. You have got, like I said, the Cowper's gland at the lower aspect, which inserts into the urethra. An inadvertently sampled Cowper gland during a prostatic biopsy might be mistakenly diagnosed as a hypernephroid variant of prostatic acinar carcinoma. But then there are some important diagnostic clues. First of all, there is no mucin outside the cells. And secondly, you have got these characteristic ductal spaces which are associated with these acini, and the presence of these ductal spaces should serve as a clue that you are basically looking at the Cowper gland and not a prostatic acinar carcinoma. So always look at the presence of these ducts within the context of these hypernephroid-like acini when it comes to recognition of the Cowper gland. Now coming to the outer aspect of the radical prostatectomy specimens, as you go from the inner towards the outer layers, you see that there are a few additional histological features that you need to keep in mind. Obviously, there will be a presence of the blood vessels within the adipose tissue. You'll also have the nerve bundles. And wherever there is nerve, there are obviously ganglia. So I guess you already know how to spot out a ganglia. You will have these structures which are invested in the perineurium, and then you have got these large ganglionic cells with the very prominent nucleolus, the vesicular nuclear chromatin, and the abundant eosinophilic cytoplasm. The presence, like this ganglia, is not actually a problematic issue. However, the paraganglion is a structure which might be sometimes mistaken as a hypernephroid prostatic carcinoma simply because the cells are often clear and pale in appearance, and they have a kind of a coalescent morphology to them, which might lead to a mistaken diagnosis of a hypernephroid grade 4 prostatic carcinoma. Be aware of the diagnostic pitfall. Now, basically, when we look at the prostate, it's just a condensation of various kinds of acini and glands within a very fibromuscular stroma. So if we are to break down the overall histology of the prostate, we'll have to look at just these two important histological landmarks, that is the prostatic acini or the glands and the fibromuscular stroma which invest those glands. So let's look at those structures in details. So let's look at the prostatic acini first. Keep an important point in mind. The prostatic acini in the region of the central zone will never look the same as when you look at them in the peripheral zone. So in the central zone, basically you have these acini which are very large glands with very complex papillary infoldings of the acinar epithelium growing into the lumen of these glands. And this is the kind of the prostatic acini that we often see in the case of the BPH specimens. And there's this important histological orientational landmark that you see. So there is the insertion of the here's the insertion of the ejaculatory duct, basically by the side which is pointed out in blue. But moving on from the central zone towards the peripheral zone, you see that the glands or the acini of the peripheral zone are much smaller in size, and the complex papillary infoldings that you have seen in the central zone are replaced by small undulations of the acinar cells growing into the lumen. So you need to be aware of the difference in the morphology between the prostatic acini of the two zones. However, if you are to keep that particular pointer away from the discussion, if you look at the acini per se, the very important thing that you will have to keep in mind is that it's always a bilayer as far as a benign gland is concerned. So you have this layer of the acinar cells, which are basically columnar cells with abundant, pale, slightly vacuolated looking cytoplasm, and with the cells which are arranged in not a uniform plane. You see that the some of the cells are lower down while some are higher up. That is usually an orientation of the nucleus that you see in the case of the benign glands, while in the case of the malignancies, often these nuclei have a tendency to settle towards the basal aspect of the glands. And surrounding this layer of the acinar cells, you have a layer of cuboidal to slightly elongated flattened cells, which is the basal layer of the cells. Now, presence of the basal layer of the cells is diagnostic of a benign prostatic pathology. And remember that as the preneoplasias and the carcinomas arise in the prostate, you have a gradual disappearance of this outer basal layer of cells, which is very important even from the immunohistochemical point of view. So, and as I said, there will be luminal secretions which are amorphous, proteinaceous, or which could take up this appearance of this kind of lamellated corpora amylaceae within the prostatic acini. In the case of a true cut biopsy of the prostate, this is how the prostatic benign glands usually look. Like we have already said, this will be kind of elongated with complex papillary enfoldings of benign glands, which is basically lined by a bilayer of the inner columnar cells, that is the acinar cells, and the outer basal cells. So over here in a higher power magnification, you see that this pale vacuolated layer is basically the layer of the benign acinar cells, and towards the outer aspect, just nestled close to the stroma, you have this layer of flattened cuboidal to slightly elongated basal cells, which is basically a sign of benignancy within this particular gland. So a short recapitulation: 2 layers within the acini. First, the inner columnar secretory cells and the outer low cuboidal basal cells, presence of which is very important to diagnose a prostatic gland as benign. Now, we will talk a little bit about the various immunohistochemical markers in prostatic pathology. The most important being the basal cell markers. We shall spend some time talking about the basal cell markers. Basically, the basal cell markers are various kinds of high molecular weight keratin clones. Now, they could be CK5, 6, or they could be a combination of various CKs in the form of CK1, 5, 10, and 14 combination, which is picked up by the basically 34 beta E12 clone, or they could be nuclear diagnostic markers like P63, which are naturally expressed in the basal cells. P63, you already know, is discussed in the context of squamous and urothelial malignancies as being one of the nuclear markers of such complex epithelial tissues. And of course, you have got specific prostatic cancer marker like AMECR or alpha methyl CoA racemase, which is not expressed in the benign glands, but as the prostate passes through preneoplasias onto frank malignancies, you have increased expression of AMECR within the cytoplasm. ERG is another important nuclear markers which is associated with the prostatic malignancies. And of course, when it comes to the issue of whether it's a primary prostate carcinoma versus versus the carcinoma from an adjacent organ, like for example, a urothelial carcinoma extending from the bladder, or maybe a metastatic, local invasion of a colorectal carcinoma, say, going into the prostate. We have got the various other markers like cytokeratin 720. We already know that the prostatic carcinoma, adenocarcinoma, is negative for CK7 and CK20. Prostatic basal cell markers, which are not expressed within the prostatic carcinomas, are often expressed within the within the spread of the urothelial carcinomas in the form of HMWCK and P63 or P40. And of course, you've got the prostatic lineage-specific antigens like PSA, PSAP, PSMA, and NKX 3.1, which is the latest kid on the block. And you have also got other important tissue lineage-specific lineage markers, which help in differentiation of metastatic spread versus a prostatic primary. But in this particular discussion, we shall mostly talk about the various basal cell markers, because an understanding of those basal cell markers will prove relevant when we move on to the prostatic malignancies. As I have already said, the prostatic acini are composed of an inner layer of columnar secretory cells, which express PSA, and an outer layer of low cuboidal basal cells, which express high molecular weight keratins, as well as P63. So the loss of expression of P63 and high molecular weight keratins is seen with prostatic intraepithelial neoplasias, and going into the stage of malignancy, there is an absolute loss of these cuboidal basal cell markers that we have talked about. So in this particular illustration, you see that there are 2 IHC markers which are basically highlighted. The first one is of the high molecular weight keratin clone, basically the 34 beta E12 clone, which picks up the high molecular weight cytokeratins within the cytoplasm of the basal cells. As you can see, there's a bit of white space within the within these cells of this basal layer, meaning that these nuclei have not got stained. For picking up the nuclei of these basal cells, you have obviously got P63, and you see that this layer of the P63 positive nuclear expressing basal cells is well developed in both these prostatic benign acini. And as you go into the HGPIN, that is high-grade prostatic intraepithelial neoplasias, and moving on to adenocarcinomas, you have a gradual loss of these basal cell markers, ultimately leading to a complete absence in the adenocarcinomas, while you have an increased expression of AMACR or P504S in the cytoplasm as you have an increased progression from pre-neoplasias into frank malignancies. And also you have nuclear expression of markers like ERG and CMYC. Now, when it comes to the individual basal cell markers, I shall, in order to make things interesting, I shall only talk about the clones which are currently available in the market. Like I've already said, this is one of the antibody clones which is most often utilized in order to diagnose the presence or the absence of the basal cell layer. Sorry, the 34 beta E12 clone, which is basically a combination of anti-cytokeratin, that is the high molecular weight keratins 1, 5, 10, and 14. So this is the most commonly utilized high molecular weight keratin marker, which is used to identify the presence of the basal cell layer. And the expression pattern is cytoplasmic. The other one, as I've already said, is P63, which is a nuclear marker, which is present in the basal cells of the benign glands, like you see in this particular case, but with a progression to malignancy, like as you see, there are some malignant glands which are highlighted towards the left, you have an absence of P63. Now, some studies say that P63 have got it has got a slightly higher sensitivity compared to 34 beta E12, but the jury is still out on that. However, it can be said with some amount of certainty that if you combine these two markers, that is, form a prostatic cocktail which can detect the presence of both P63 as well as 34 beta E12, you have got a prostate cocktail 2x, which has got a sensitivity which is higher than any of these two markers in isolation. And now this particular marker is the granddaddy of them all. We call it the PIN4 cocktail, which is basically a triple marker, which is basically a triple marker cocktail, which helps to pick up at the same time not only the presence or the absence of the basal cells, but also the expression pattern of AMACR within these glands. So you see that the individual components of this particular marker are, first of all, high molecular weight keratin 5 and 14. At the same time, the nuclear marker, that is P63, which are basal cell markers. So all these three markers for the basal cells are actually labeled to the horseradish peroxidase and Dept chromogen. So they will stay in brown basically, while the AMACR is basically labeled out with alkaline phosphatase and the fast red, which the presence of this AMACR will be picked up in red. So basically, if you see that a gland lacks brown outside and is pink or reddish inside, you know that you have got a bad gland over there, which is expressing AMACR and not expressing the basal cell markers. The importance of this particular cocktail mostly stems in the case of prostatic true-cut biopsies, where you might get a suspicious gland which you call Asst, and then you cut a deeper section and you see that the gland has basically disappeared after 2 or 3 deep sections. In such cases, it's better to leave one unstained slide in the middle of the 2 cuts, which you can at the same time test for the presence or the absence of all these 4 markers just with a single antibody cocktail. So that's why this particular marker is of diagnostic importance in prostatic pathology, especially in true-cut biopsies. Now, in this particular illustration, it highlights almost everything that is to be known about this particular marker. As you can see, there are benign glands over here, which are nicely picked out with the outline of the basal cell layer in brown, while these glands don't express AMACR. On the other hand, you have got this infiltrative acinar adenocarcinoma of pattern 3 mostly, which lack the basal cell layer. As you can see, there's no brown around the glands, but at the same time, there's a strong cytoplasmic expression of AMACR, which is basically labeled out with fast red, which is why they have picked up the red color in the cytoplasm. So you have got these atypical red positive, brown negative glands, which are infiltrating through the brown positive and red negative benign glands of the prostate. You achieve 2 things at the same time. You achieve the diagnostic certainty that these atypical glands are expressing AMACR, and you can also establish the fact that there is an absence of the basal cell markers. This is the last part of today's discussion, where we talk in little detail about the radical prostatectomy procedure. Now, I'm of the firm opinion that in order to understand the process of grossing, you need to gross one specimen. Just me talking about the grossing procedure in a virtual lecture might not attain the entire objective. However, it's a start. There are some excellent YouTube videos which are available on the net, which show you the process of the of grossing the radical prostatectomy specimens. In your spare time, please go through them. You will have a basic understanding of how to approach this particular specimen. But in short, when you get this prostatic gland, the first important thing that you do is you run a probe from the base through the base and exit at the apex, thus holding the prostate in the pattern of a shish kebab. And then you take two inks to this specimen and basically mark out the right and the left halves of the prostate, inking out everything. So you ink out both the prostate as well as the seminal vesicles along with the along with the duct difference on both the sides. You can have your own pick. Maybe you could have a right orientation for the black and the left for the blue. Some prostatic specimen grossing protocols actually call for 4 colors, wherein you use yellow as well as green to mark out the right and the left lateral aspects of the prostate. Now, that is not something which is routinely followed across multiple institutes, simply because it adds some more layer of complexity to an already complex grossing procedure. But inking the specimen is mandatory because you need that orientation when you are going to see the slides microscopically. So there are a few important things that you need to keep in mind. The first thing is to cut out the vas difference margins and give it out as the right and the left vas margins. The next important thing to do is to basically take out thin slices of 5 mm thickness at the level of the base as well as at the level of the apex. Apex first, followed by the base. So this is important because these are two important landmarks which have to be studied in order to check for the extension of the prostatic carcinoma. Now, after you have fashioned out these two levels in the form of these two narrow cylinders, you basically take a knife to these levels and then cut out these particular levels in a perpendicular fashion, so that basically the right and the left halves of the prostate are sampled out in their entirety and given on their end face margin. So you have basically sampled the apical margin and the base, and you have given it out as the right and the left prostatic apical margins, that is the distal urethral margin, and the base margin, that is the proximal urethral margin. And now the next important thing to do is to basically cut out the seminal vesicle and the ductus deferens from the main prostatic specimen, because you want to also give sections where the seminal vesicle inserts into the prostatic parenchyma, and you have to submit the insertion of the seminal vesicle with the prostatic parenchyma as the right and the left sided ones. And now you are left with the bulk of the body of the prostate, which you will have to basically section parallelly as multiple sections. Now, if you see the order in which these particular levels are basically laid out, you start off from the apex and slowly make your way up and end with the base. Now this kind of labeling it out as 1, 2, 3, 4, etc. helps you in order to orientate the specimen when it comes to grossing, and also to have a microscopic idea when you see the slides. Okay, so now the apex and the base have been sectioned out in a perpendicular plane, and you have to submit the apex and the base in the entirety. As you see, this particular grossing of the prostatectomy specimen is via a regimen which utilizes the 4-color approach. Most of the institutes will go in for the blue and the black combination alone. After you have given out the apex and the base as perpendicular sections, you are now left with the bulk of the prostatic body. So in this particular case, actually, different institutes follow different protocols. Now, ideally, you should actually section out all these levels as quadrants, or if the section is pretty large, you might even have to give 6 sections. You might have to sextant it out. However, because that will lead to probably around 45 or 50 or more number of blocks of the entire specimen, and the cost factor might not justify such a kind of grossing. In that case, you will have to basically search out for areas which are suspicious looking, like over here you see the suspicious areas which are being highlighted by this cursor moving around. And these areas are important because these are the grossly suspicious areas of the prostatic adenocarcinoma. One approach that I use is I usually go back to the prostatic biopsy specimens and look at the areas where the bulk of the prostatic carcinoma was actually reported out, and then try to correlate it to the level which I am seeing in the gross specimen. So you have to submit the entire prostatic cancer that you see grossly, including the dominant nodules as well as the smaller nodules. You have to be able to segregate out the areas of the benign prostatic hyperplasia from these carcinomas. That is not a very easy thing to do. And keep another thing in mind, that the areas which look more or less normal in gross might turn out to have malignancies microscopically. So the best way would be to give off the entire prostate, but again, cost will dictate the approach that you choose. Quadranting out these particular levels is important. So there is this book called Wizderm, which actually gives an approach for the prostatectomy specimens where after grossing, you don't come across grossly visible prostatic cancer, in which case he advocates giving all the posterior sections of the prostate and one anterior section from the right and the left side, because that probably optimizes the yield as far as the search for prostatic cancer is concerned in a specimen where you don't have grossly appreciable prostatic cancer element. We have almost reached the end of our discussion. A few pertinent facts about the prostatic needle biopsies. The kind of prostatic needle biopsies which was priorly practiced in the past was the sextant biopsy sampling procedure, which basically targeted the levels of the base, mid-gland, and the apex at the levels of the peripheral zone and the central zone. However, this has now it is actually being phased out, and it is being replaced by the extended biopsy sampling procedure, where you see that there is a lot more sampling of the peripheral zones going on. And this part, which has been basically blacked out, is the region of the transitional zone. Now, the transitional zones are usually not sampled in the initial biopsy approach, while in a case where you are having persistent negative biopsy findings, the repeat biopsies will also target these transitional zones of the prostate. So this is the extended biopsy sampling procedure, which is now known as the systematic biopsy procedure, wherein basically you have got the base, the mid-gland, and the apex sampled out as the right and the left, as the lateral and the medial aspects of those two sides of the prostate. An interesting tidbit about how you should actually section those true cut biopsies that you get. Now, this I came across a textbook. I came across this fantastic textbook, which is basically the Diagnostic Pathology series. And in order to optimize the utilization of IHC, what he advocates is basically giving out multiple sections, but taking care that the odd sections are kept unstained. This is important because suppose you have got a focus which is suspicious on the first level, you will ask for the second section to be kept unstained for IHC if the need arises. If you have moved on to the third level and if you see that the gland has disappeared, that means that there might be a chance that you can utilize IHC in order to highlight the presence of that atypical cancerous gland in the second level, and so on and so forth. So this is a way in which you can justify the limited amount of prostatic tissue that you have and still be able to utilize those diagnostic markers in order to reach a diagnosis of an adenocarcinoma. Thank you very much. However, before I end off with this discussion, little bit about the important things that you are supposed to keep a note of as far as grossing is concerned. As you see, you have to measure the volume of the specimen by the liquid displacement method. You have to measure out the prostate as well as the seminal vesicles. You will have to pay attention to the resection margins. The resection margins are basically the inked peripheral aspect of the prostate, which you see in the sections from the prostatic body. You will have to talk about the involvement of the apex and the base, which are very important landmarks as far as the orientation as well as the grossing is concerned. You will have to talk about the status of the seminal vesicles and also the pelvic lymph nodes. This brings us to the end of this discussion about the prostatic pathology, that is the prostatic gross and the histology and the basic immunohistochemistry of this important organ. And understanding of these few topics will actually help you as you move ahead in prostatic pathology and you come across the various pseudoneoplastic and the neoplastic entities that you see. Thanks a lot.